gentlemen, welcome back to the second Gajah Mada International Conference on Tropical Medicine GAMA-ICTM 2025. Thank you so much. Hopefully you are ready. Grab some coffee and some refreshments to be ready to join the first symposium.
Yes, exactly, Wes Yomi. This first symposium will talk about a looming threat, an innovation breakthrough in malaria control, and this symposium is led by Professor Elsa Herdiana Murhandarwati. A brief introduction about her, dear ladies and gentlemen. Professor Elsa Herdiana Murhandarwati is a professor, lecturer, and researcher at the Department of Parasitology, Faculty of Medicine, Public Health, and Nursing, Universitas Gajah Mada. She is also the head of academic affairs for the postgraduate program in tropical medicine here, and the program coordinator for the special program of implementation research in tropical diseases at Faculty of Medicine, Public Health, and Nursing. She also leads the malaria research group here at the Center for Tropical Medicine, focusing on malaria, molecular diagnostic, and elimination strategies. She also has guided a lot of various activity regarding capacity building initiative for health professionals, including good clinical laboratory practices, training, and malaria diagnostic standardization. I was a little bit nervous actually.
Okay, so ladies and gentlemen, without further ado, let's invite Professor Elsa Herdiana Murhandarwati.
Okay, thank you, Mbak Rima and Mas Yopi. Yeah. Just for correction, I'm not again the head of academic affairs of postgraduate of tropical medicine. Yeah. Okay, good morning, ladies and gentlemen, and welcome to today's seminar, the first sessions of this symposium on malaria, a looming threat and innovation breakthrough in malaria control. So as we know that malaria is still a public health challenge in the world, including in Indonesia, affecting millions of populations. Even though we have made a lot of progress in prevention and also in the detection, yeah, but it's still a big threat. Malaria is still a big threat to global health. So today we will hear from our esteemed speakers about the latest innovations in fighting malaria. Now let me introduce our speakers. Our first speaker is Professor Erni Juwita Nelwan from Universitas Indonesia, and she's joining us virtually and will be talking about the development of malaria vaccines. Mbak Rima, can we show Professor Erni profile here? And then we have Dr. Triwibowo Ambar Garjito from BRIN, who is an expert of mosquito. The mosquito man, is it right, Pak Triwibowo? He will be discussing how climate change relates with the vector expansion and then have impact on malaria. Lastly, we will have Dr. Henry Surendra from Monash University Indonesia, who will talk about challenges in early malaria detection. So, welcome, esteemed speaker. Let us give applause for our speakers. Ladies and gentlemen, I'm sure that during this presentation, you will have some question because it's very interesting and thought-provoking question also. Yeah. So I encourage you to ask the question to the speakers. We will have Q&A sessions, but after all of the speakers finish the presentation, Yeah. So for participants that join us in Zoom, then you can start, yeah, to ask your question to the chat room. Yeah. And for you that join here in person, then you will ask directly to the speakers at the end of the presentation. Okay? Okay, so ladies and gentlemen, without further ado, okay, please welcome everyone Pak Triwibowo Ambar Garjito, Climate Change and Vector Expansion.
Thank you very much, Professor S.Si, for the time. And first of all, I'd like to thank you very much for organizing committee, GAMA-ICTM 2025, for inviting me. And today, we would like to discuss it because of actually maybe some of the participants here also has experience for the vectors study. So we'd like to discuss about the climate change and vector expansion. Yes, yeah, this is the, I would like to talk about the climate change and malaria vector expansion problem and challenge in Indonesia. So, when we talk about the climate change is one of the greatest threat to human health in the 21st century. And during hundreds years, so global mean temperatures have already increased by 1.1 degrees Celsius, and the sixth assessment report of the Intergovernmental Panel on Climate Change explained that the global average will reach or exceed in 1.5 degrees Celsius in the next 2 decades. So the climate change is expected to worsen the risk of vector-borne diseases, especially mosquito-borne diseases, and it will give a big impact for the human being. Yeah, next. This is one of the risk factor before we talk about the climate change in general. So this is the one of the risk factor of spreading vector-borne disease and zoonotic disease. This is the illustration, the figure that explain about the deforestation in many places in some location in Indonesia. This is in Kalimantan, North Kalimantan, and also in East Kalimantan. This is also a give impact for the transmission and distribution of the vector-borne disease. Next. Yeah, when we talk about the climate change, so this is the report from the IPCC in 2014. During the 1986 until 2005 to
recording in progress.
2080 until 2100. This is the prediction. It's a predict that the temperature will increase up to 11 degrees Celsius. So it will give the big impact, especially for the environmental and also the public health in general. So when we see about the change in average precipitation, it will give impact until 50% of the precipitation in the world. Next. Yeah, this is the main surface air temperature change in the past 50 years compared between 1956 and until 1976 compared with the 2011 until 2021, and we can see that the temperature increased until 4 degrees Celsius, especially in the North Pole. In the equator area, the increase of the temperature is about 0.2 until 1.0 degrees Celsius. So this situation will intensify the precipitation pattern and also accelerate the melting of glaciers. So it will give the contribution to the rise in a sea level. So the climate change will accelerate the more frequent extreme weather and posing severe risk to human life and human being. Yeah, next. This is the other risk factor of spreading vector-borne diseases that are caused by high shipping and flight. Yeah, this is the example in Indonesia when we talk about the shipping and flight. It's 100 shipping and flight occur during a month. So we can see this is very important situation and increasing the risk for the spread of the emerging and re-emerging disease transmitted by disease vector to Indonesia. Yeah, next. Okay, when we talk about the vector-borne disease, especially in the mosquito, so we should know about the location of Indonesia because of our location is reinforced of two biogeographical zone. In the western part is influenced by Asian organism, and then the eastern part is more influenced by Australian and Pacific organism. In the middle part, this is combination between western part and eastern part. So this is a more diverse city of the organism, including the mosquito. So due to the various habitat and various ecosystem, so in Indonesia contain many endemic and unique wildlife. Currently, at least 437 species of mosquito are reported in this country, and not less than 36 species of fleas reported also in Indonesia. Yeah, next. Next, yeah. Okay, this session we talk about the malaria vector. So we would like to know about the Anopheles mosquito and climate change. So we know that Anopheles mosquito is the vector, main vector for the malaria, and also we can talk the main vector in East Nusa Tenggara and also in Central Sulawesi for the lymphatic filariasis and also Japanese encephalitis. So to understand the Anopheles mosquito and its behavior in associated with climate change is essential to for us. So this is environmental change, climate variability, and climate change could affect the biology of and ecology of the Anopheles vector. So we know that mostly of the Anopheles is active during the night. So we call it as nocturnal activities, mostly nocturnal. But we have also the Anopheles that are biting during day and nights in East Nusa Tenggara. Closing with the Kupang, maybe some of several participants from the East Nusa Tenggara know about the Anopheles pyrrhostris in Kupang. The species is have activity during the day and night. So Anopheles is also poikilotherm, dependent on the ambient temperature in their life history. So the poikilotherm effect can give effect for the biting rates, duration of their gonothermic cycle, fecundity, survival and development of the immature mosquito, and vector distribution and expansion. Okay, let's see about this next slide. Yeah, this is the recent worry situation, especially in Central Asia and also in Africa, about the occurrence of the Anopheles stephensi and the change behavior of the Anopheles stephensi from the rural area into the urban area. So we can see during the maybe last decade, the expansion of the Anopheles stephensi is very fast and spread in a very wide area. We can see the green one. This is the new country that invaded by Anopheles stephensi, and also the country at least reported in a red. Yeah, next. How about the Indonesia situation? So this is the recent human malaria situation in Indonesia. We still have big problem in Papua and West Papua, and also in East Nusa Tenggara and little bit in East Kalimantan. Yeah, next. So this is the progress of Anopheles taxonomy studies in Indonesia since 1900, that started from the Nicholas Hendrik Swellengrebel in 1921, who identified 29 species of Anopheles, and then some others experts in mosquito also try to identify more about the more complex about the species of the Anopheles. And currently, based on the O'Connor and Supanto in 1979, we have identified 67 species with 1 subspecies and 4 variation of the Anopheles taxonomy. Yeah. Next. So, why Indonesia has various species of the Anopheles? Because we have a very unique archipelago. Our archipelago consists of several parts from the western part of the ASEAN part, and then in the eastern part, this is consists of the part of the Australian continent, and in the middle we can see this is also a part of the Pacific that also join to be one big island that we call it Sulawesi. So when we see the color here, maybe we can find some species that cannot be found in the eastern part. For example, Anopheles sundaicus, and the species only found in the Sumatra, Kalimantan, Java, and also Sulawesi. But for the Farauti complex, we just found the mosquito only in the eastern part of Indonesia. Yeah, and this is very unique because of we also unique species only found in this area, and we cannot found in the other area because of this part is similar with the species in the Philippines. So I think this map is very important also to make sure the distribution of the Anopheles in Indonesia. Yeah, next. So we said the archipelago that's very unique. This is also the existence of the ring of fire along the Indonesian archipelago. We have a ring of fire from across from the west, from the Sumatra and then Java until the Malucas. So this is very important to make a barrier geography for several important malaria vector in Indonesia. Yeah. Next. So based on this situation, so now we have a lot of mosquito actually in Indonesia. In Java, we can see about 31 species of Anopheles have been identified. In Sumatra, it's about 36 Anopheles have been identified. And next. This is in Kalimantan and in Maluku. And next, okay. Yeah. Sulawesi and West Nusa Tenggara and East Nusa Tenggara, Lesser Sunda Archipelago. And next, this is species Anopheles in Papua. So the mosquito in Papua is very unique and only similar with some species in Malucas. Yeah. Next. So according this data, so we also have good information about the malaria vector and their distribution in Indonesia, and we just finished update this data in 2023, and we got about 29 species that already confirmed as the malaria vector in Indonesia. The data is already published by Ministry of Health in 2023. Yeah, next. So actually, with various species of the vector in Indonesia, especially for malaria vector, Ministry of Health has specific strategy for malaria elimination. So this is with LLIN and also IRS is the main strategy that used now in especially in high and medium endemic area, and then add with larva source management that also implementing together with the LLIN and IRS. Yeah, next. So, however, even though we have various mosquito, we have intervention and we have some barrier geography, and we have some problem related with the global warming, but the distribution of the Anopheles so far not expand to the other location. It means that the species composition in Java is still like this since 100 years ago, and in Kalimantan also like this. Yeah. So I think this is important to know because of not all species of Anopheles can expand easily. So this is the problem actually for and challenge of malaria vector control in Indonesia.
Actually, the problem is come from the various of species Anopheles that have been confirmed as a malaria vector. High variation of malaria vector species, and then different bionomic vectors, and then different inviting preference and breeding habitat, and then also insecticide resistance status. This is that give impact on the vector control method planning and intervention. So far, the climate change is not give a big impact for the distribution and the control for the malaria vector in Indonesia. Yeah, next. Yeah, this is just one example about the Anopheles maculatus that now we will give the new name, especially in Menoreh Hill, because the species is no more Anopheles maculatus because the genetic characteristic is already different. Yeah, next. Yeah, we already studied this mosquito, and we got this is a different branch of the species Anopheles, and in part of the Anopheles maculatus complex. And hopefully this year we will give the new name. Hopefully the new name is the Anopheles bangensis, because we would like to tribute this for Michael Bang, late Dr. Michael Bang, and this is the important mosquito that should we know because of this is the one of the main vector of the malaria in Menoreh. Yeah, next. So why the species is different with the other species Anopheles maculatus in the world? Because this species of mosquito in the Menoreh Hill is buried by a geography for many years ago, for about 25 million years. So the species stay in Menoreh for 25 million years and did not disturb by everything. So the location is safe from the eruption, from the Merapi eruption, Merbabu eruption, and also from the what is the name? Dieng eruption, yeah, Dieng volcano eruption. So this location is very safe, and the mosquito with their careful develop by themselves. So due to the barrier geography that for many long time, so the species is to be a new species, different species with the other. So this is not expansion, but this is due to the natural situation for the long time. Okay, yeah. Next. So the other problem is about the threat of zoonotic malaria in Indonesia. We can see that now currently we have a threat related with the zoonotic malaria due to the land use change in many places in Indonesia, especially in Sumatra and Kalimantan. Next. Yeah, this is some. There are some publications that released by our colleagues in Indonesia that explain about the risk of Plasmodium knowledge transmission, and we can see the number of cases already reported in many places, especially in Sumatra and also in Kalimantan. Yeah, next. So this is the prediction of geographical distribution that already published by Freya, our colleagues from Melbourne, that explain about the risk factor due to the land use change. So I think the climate change give impact especially for the simian malaria vector currently. Yeah, next. Now we can see about the Anopheles leucospirus group in Indonesia. Before 2020, we have only a limited species of the Anopheles leucospirus. But after we identify correctly by genetic and also by morphological, combining between genetic and morphologically, we got a lot of species of the Anopheles leucospirus that have give a role as the potential vector for the simian malaria. Yeah, next. So this is field activities that we try to find is there any impact of the climate change, and is there any impact of the land use change to the distribution of the vector that we work together in with Mas Henry in a Zoomal project. Yeah, next. So this is our paper that explain about the zoonotic malaria transmission and land use change in Southeast Asia, and we identify the location and the distribution of the some species of the simian malaria vector in Southeast Asia. Yeah, next. And this is the recent publication, recent paper that we just published in 2024. The risk of the Plasmodium cynomolgi transmission in Indonesia. Yeah. Next. So what should we do with this our situation? So come back with this our business that for control malaria, especially for vector malaria in Indonesia, we divided based on the habitat type: coastal area, swamp area, and then paddy fields. Next, hilly area, forest area, and plantation area. Yeah. Next. And this is one of the our approach that successfully conducted in many places, especially in the coastal area. And now almost of the coastal area already eliminated for the malaria transmission. Yeah. Next. This is the situation in coastal area with Anopheles subpictus, Sundaicus, and Epiroticus present. And currently, this vector is not look like 10 years ago, because now almost of the area with the Sundaicus species already eliminated. Yeah. Next. Yeah. Why we use this management, environmental management? We just follow what Dr. Swellengrebel did in 100 years ago. So we still using the same approach to control the breeding habitat of the Anopheles sundaicus, Anopheles subpictus, and Epiroticus in coastal area. And this still successfully. So it's mean that even though the climate change is already come, but we still using the old method that still have a very good result for the implementation for the vector control in Indonesia. Yeah. Next. So based on all of our discussion, so climate change might influence the bionomic traits of malaria vector in Indonesia, but no range expansion of Anopheles species has been reported to date. And despite this potential impact, there is currently no evidence of climate change-driven malaria vector expansion in Indonesia. And of course, we're still using long-lasting insecticide net, indoor residual spraying, and also optimized larva source management as the primary strategy for malaria control in Indonesia. And then climate warming that alter microclimatic condition of Anopheles mosquito in the highland of forest may facilitate the persistence of the malaria mosquito population, especially simian malaria vectors. That's it, my presentation, and thank you very much.
Thank you, Pak Triwibowo, for the enlightening presentation. Thank you also for take us to the Jurassic time, yeah. So we have time traveling and see our ancient Anopheles, yeah. Okay. After this, we will move to the second speaker. Now it's Professor Erni. So Professor Erni Juwita Nelwan. So we can see the CV of Professor Erni here. Yeah. So Professor Erni is from the Universitas Indonesia, Division of Tropical Medicine and Infectious Disease, Department of Internal Medicine, Fakultas Kedokteran UI, Universitas Indonesia, member Antimicrobial Stewardship Team, Internal Medicine Department, RSCM, also a member of Development Team for Adult Bone Marrow Transplant Services, and a lot of experience in malaria project and study. So without further ado, please welcome our first speaker, Professor Erni Juwita Nelwan. Professor Erni, you ready, Prof?
Yes, Prof. Elsa, thank you very much for your kind introduction. I hope my voice is clear enough to hear, Prof.
Yeah. Please, Prof. Erni.
Okay, thank you for the time. First of all, I would like to thank the committee that invited Indonesia to share these important topics regarding malaria. Is my slide still okay? Yeah. I received the title about the advancement in malaria vaccine development progress and future direction. And in this session also, I would like to share a little bit the work of vaccine trial that already been conducted in our country, and how this will also share important information for the malaria vaccines in the future. Yeah, as we understand that there's still high risk of getting malaria, not only in the endemic area, but also from people living in the area free of malaria while they travel to different parts of the world, they might get the risk. And what we have until now is only the chemoprophylaxis. And with the chemoprophylaxis for the persons that will be staying in a longer time in a highly endemic area, this will be another challenge, because that the limitation of the safety of the chemoprophylaxis, as we know, might not widely known. So we need to stop the drugs taking the chemoprophylaxis in somehow. And also the adherence that might give another challenge whether the medicine will be taken. So in another way, we try to do the other prevention methods, like using the repellent to avoid the mosquito bites, using the nets with the insecticides, and all these mechanisms that have been trying to be implemented, still showing the high mortality and morbidity data worldwide. So what we have now seems not enough. So then, of course, we know that the vaccination is the most effective way to prevent infectious disease, including malaria. And then the global technical strategy already set 90% target to reduce the case of new malaria infection and mortality around the world. But the thing is, as we can see here, it is not easy to just make a vaccine, in particular in malaria. We will going to discuss this later, but then as we can see in this slide, that there are 133 vaccines available, 229 clinical trials ongoing. This data retrieved in October last year, but I believe not quite much changing until now. But then we can see that what we have now that can be used as a vaccine to protect our population is only 2 available vaccines with also several limitations. So why is that? Why is it so difficult to make malaria vaccine? We need to understand that the malaria life cycles is quite challenging, because the parasites lives in 2 different parts, in humans and also in a mosquito. So we really need to know where we can stop the replication of the parasite to then further causing an infection. So in malaria, it's not only an infection, but while it infected someone, we know that there could be a severe form of infection or the uncomplicated one. So it is also important asking the question of making malaria vaccine. What do you want? You want to stop the infection, or you actually want to stop the severe infection to stop or to decrease mortality? So this is what we need to solve to get the most effective vaccines to be implemented worldwide. So we know that while the sporozoid inoculated to the human blood, and then it will transform in the liver sites of the human into the from the sporozoid become merozoids, before merozoids to C-zone, and then merozoid to C-zones, and then to trophozoid, and then infected the red blood cell. So is it possible to stop all these phases of infection? So let's see what we have. So this is the stage of malaria parasite life cycles, and then this is the potential uh, vaccine that's available. So as you can see here, we have the PFS25, PFS22, 2030, and then that's from the transmission blocking vaccine. We will go further explaining one of the vaccine works later on. But so as you can see here, this is so much things to do to stop the replication of the parasites. And also, maybe if it's effective in one way, then another phase, like for example in the mosquito, when it's not stopped, so the transmission could still probably happen. Then this causing another question on how we can actually make the whole package of vaccine that could really give an impact in reducing number of cases and also mortality. So I'm going to go through for the vaccine that already roll out and see, because what happened now is what's been going on now is we are trying to improving the one that already been approved by the WHO, and yeah, inshallah Indonesia will also contribute to the further the next trial that going to be run. So we know the RTS mosquito vaccine already approved in 2022. And a year later, the Matrix M, the R21, also already approved, and both is only being given for children. And the R21 is actually will be available also in Indonesia. So first we have to understand that this is the vaccine that using the circumsporozoite protein. So this is the protein that available in the surface of the sporozoite stage, and then it will later on induce the antibody. And as you can see here, that the vaccine works is in the human part and not really stop anything from the human part to the mosquito. So then with this situation, the transmission in the population will remain the same. The vaccine itself still can cause this disease, but the vaccine itself will not protect you for having the infection, but it will protect you to having the severe infection. Yeah, and then up to now, it's just only be recommended to give in children with 4 doses, and then another booster 1 year later if they are living in the highly endemic area. So how might this vaccine work? You can see here that it can reduce the severity of the infection in 30% of the vaccinated children. So maybe this is not the best vaccine available that we wanted, because that the protection is quite low. But even though in the area where the mortality of the malaria is very much happen in children, so then this is considered as quite acceptable to be implemented. So we know that we expect to have the protection of at least 70% of population get the vaccination. So as you can see here, that the vaccine efficacy is actually not really that good. However, this is what we have until now. And then in certain area, for example, in a study that they conducted in Kenya, there are not really significant protection can be seen. But we have to understand that doing a trial of a vaccine in a highly endemic area quite probably difficult because of the highly transmission during the vaccination. So when you start to give the vaccine to the population or to the participant of the study, the potential transmission is still happening and going on. So then it's quite challenging to the person to have enough time for the antibody to be released or to be formed, and then enough to give the protection. So this is quite a challenge, and this is also one of the let's say the advantage of doing clinical trial in Indonesia, because we have in one country different endemicity of malaria, so we can perform the vaccination in the very low or no malaria area and see the efficacy of the vaccine in a highly endemic one that going to be discussed a little bit later. Yeah, so this is the R21 vaccine. So sorry for the misspell. So the R21 is next generation. Why is that? Because it consists a lot more protein than the previous, the RTSS. So then it's easier to stimulate the antibody response, and then also in the manufacture aspects, it's more easily to be reproducible. It will be given at the same doses with the same number of vaccination, and also still will be used more to in children. We have also need to understand that the situation of malaria, perhaps in Africa, where the vaccine is first rolled out to the population, is actually different with the setting like in Indonesia, because we also have substantial amounts of an adult that travel for the no malaria area to the highly endemic area, such as Papua, for example. So this is the R21 vaccine that yeah, so probably available soon in Indonesia. I think we are on progress to have this. And from the trial, it shows that over a year, the vaccination can be as 79% to 75% to 79% efficacy, which is this is way much better compared to the RTSS that previously already been approved by WHO. So as we can see that it is not easy to have a good result of malaria vaccine, in particular if you conducted the study in a highly endemic area. So then the challenge to have the good efficacy results is a question. But on the other hand, besides of the setting, but there's also the complexity, as we already talked. The cycle of the malaria makes the problems is adding to answer the availability of us having high efficacy malaria vaccine. And we have to also understand that in Asia, we also still have 5X infection instead of falciparum. We know that 5X one causing fast mortality. So if it's delayed by diagnosis, then the chance of death is increased too. But the attention of malaria vaccine is more to the falciparum. So as you can see here, there's if we look at the human malaria trials vaccine, can see that there's one study only been going on in Southeast Asia, and this is also only focusing in falciparum, while perhaps we need also an intention on how to get protection from the infection of 5X malaria that can causes relapses episodes. So for the next maybe 5 to 7 minutes, I would like to share the Indonesian sporozide vaccine trial. The study is already finished and had been published on not the result of the vaccine, but on how we can conduct the trial, because this is also really some things need to be carefully designed and think to have good result and share an important information regarding the efficacy. So here's, we studied the two vaccine, the sporozoite irradiated and the live one. So, but the live one, we added with chloroquine so the parasites can be directly killed by this medicine. So we give 3 times injection, direct venous inoculation. So we want to target the sporozoites, so we could not administer it intramuscularly. So we administer it venously. And we conducted this trial in an area of Sumatra when they don't have malaria there in this area. And we also screen all the participants that they have zero malaria in their blood. And then we deploy them to Papua. The study is conducted in a conjunction between FKW, the Army, and also Sanaria as a sponsor, and also Eijkman Oxford Clinical Research Unit in FKW. So then we deploy them. So we know that we give time from the vaccine because they need to travel around 2 weeks from Sumatra to Papua. So we give time for the antibody for the parasite to stimulate antibody. So then this is how it works. So when the sporozoite vaccine goes into the liver stage of the parasites, then this is the live one. This is the live one, not the attenuated one. So then it starts to replicate. But at the same time, as I mentioned, we already give every week chloroquine to be able to kill the parasite when they release into the blood from the liver. So because we really need to know like the exact situation when we get the infection. So the sporozoite, live sporozoite, goes into the blood and then get killed by the chloroquine. So maybe I'm not going to share about the result. We got almost 60% efficacy from this trial, but as you can see here, that the vaccine trial really needs time. We initiated in 2018, and then the COVID-19 happened. We need to postpone, and then we need to also initiate again the ethics committee, all the permission administration reasons need to be sure to be done before we did the trial. Of course, because we also involving vulnerable participants like the army there, and this army is the one that going to the battlefield. So this is really something need really to be in a very safety procedure. So we get an approval in 2022, and then conducted the pre-exposure in Sumatra, deployment, and then during the deployment time, we collect more than 10,000 blood samples. We observe every week, even every day, the potential of the adverse events, and we need to do the reporting, not only to the Indonesian authorities, but also to the US authority as the sponsor, as the company is a sponsor from the Samaria. And we also need to observe the participant actively without signs and symptoms every 2 weeks. So this is the team. As you can see here, that we need to really able to design very well, like I mentioned, to get the high quality of results that can be used as the reason for us to then further disseminate the vaccine, of course, to the community. So, yeah, we also learn from this vaccine trial that we are using the strain that completely different with the strain that circulated in Papua. But the result showed that the antibody can be increased comparing the placebo and the one that receiving the vaccine. So this is a clue and a hope, of course, for us that you do not need to have the strength for your own to get the antibody response. Yeah, this is also happened in COVID-19 because we do not really need to have the strain as our own to make our own vaccine. But it shows from this trial that the antibody still can be formed and released even if you are not using the strains that circulate in your area. So this is the result. We have two groups. This is the group that attenuated sporozoites been given. And as you can see that the placebo is the one with the blue line and the red dot is the vaccine. And you can see here that we get a different bar chart. This is showing the protection. And also for the one that's live and challenged with the chloroquine. So I would like to conclude my talk with saying that we show that we could have the safe, well-tolerated, and immunogenic malaria vaccine. And then with this vaccine, with this sporozoite vaccine, showing that you got the protection of the infection, not only the protection of the severe infection. So you won't get sick. It is the new hope for the future study of malaria. And there's also a hope to improve the R21 vaccine that will be given higher efficacy to be used in the future. And we are excited to wait for the trial to be conducted also here in Indonesia. And yeah, sadly, that the vaccine that designed for Plasmodium falciparum is not showing any protection against malaria vivax. Yeah, this can be also learned from this trial because of in Papua, the chance of having falciparum and vivax infection is around 50-50. So then we can see that the reduction of falciparum patient is there, but the number of vivax infection is still high, and no difference between the vaccinated and not vaccinated group. So this is a huge collaboration with all this group of team. And with that, I would like to end the talk. I give back the time to you, Prof. So thank you very much.
Insightful presentation. Let's give her a big round of applause. Thank you for sharing your experience, more than 5-year experience for clinical trial with the new vaccines. I think it's promising. And please still keep your question. We will have a discussion time later after the third speaker. Now I would like to invite Dr. Erni Surendra, our next speaker. This session, he will deliver a topic about early detection challenges in malaria. So here is the profile of Dr. Erni Surendra. Yeah. Oh, this is also Pak Triwibowo, yeah? We missed it in the first session. Okay, Dr. Erni Surendra, so the floor is yours.
Thank you very much, Prof. Elsa. So I stand over here. Okay. Good morning, everyone. Just quick vote. Anybody here had experience with malaria? I mean, have any of you got infected by malaria here? No? Oh, okay, we've got 1, 2. Okay, cool. 2 people, not cool. I mean, like, well, at least you know how it feels, right? Okay, so today I'm going to be sharing a bit of perspective around early detection challenge in malaria globally and also in Indonesia. What's going on? Okay, this is just a quick outline. So I'm going to talk a bit about malaria situation in global Indonesia, and also why is it important, to understand about the challenge related to early detection in malaria elimination context. What are the challenges itself, and then what can we learn from the existing knowledge available now? There you go. Okay, just a brief overview on the global malaria situation now. So this is the map that I just took from the World Malaria Report in 2024, published in December 2024. As you see in here, there is ambition globally to achieve malaria elimination by 2030, actually, but then if you notice here, the green part of the maps actually show the countries, endemic countries that already been certified malaria-free by the WHO. In terms of number, you can see that only 44 countries, so it's just above 50% of 83 endemic countries actually have been certified for malaria elimination, meaning that we still have a lot of works globally. And if you see also, Indonesia is still white, meaning that we haven't achieved our elimination as well. And based on the report from the WHO in 2023, there were around 263 million new malaria cases, which is actually increased if we compare it to the data in 2022, which was 252 million. And malaria deaths reached more than 500,000 in 2023, which is again highlighting how important and how challenging malaria is. There you go. Just a bit of overview about where are we now in terms of malaria globally. In Indonesia, actually, we now account for 27% of malaria cases in the WHO Southeast Asia region, just second after India. And the report from WHO suggested there was no difference in case incidence compared to the previous year, meaning something wrong. And in fact, there's an increase of mortality rate in malaria by 6%, as you can see from the graph here. I've highlighted over there. The orange shows that actually like we stuck in terms of malaria incidence, but in terms of mortality, the green one shows that there is an increase of mortality rate in malaria in Indonesia. Part 3 also briefly mentioned about the challenge of P. knowlesi malaria, which is zoonotic malaria transmitted by mosquito bites from infected long macaques and pigtail macaques to human. Maybe next, someone. We observed that in Indonesia now we are experiencing increasing trend in terms of number of P. knowlesi malaria cases in our region, which is also concerning. Next, and then why is it important to know, why is early detection important in the context of malaria elimination? According to the Global Technical Strategy for Malaria 2016 to 2030, the WHO highlighted that it is really important to transform malaria surveillance into core intervention. What does it mean? Meaning that early detection is important and become increasingly important as the transmission decline. If you see the map over here on the right side, this one represents high endemic setting, endemicity, moderate, and then low, and also elimination setting. As you can see, as the transmission decline, actually early detection become more important. Why is it? Because, for example, in area with very low cases of malaria or even who have already eliminated malaria, identifying one single infection is really crucial, because then only after we're able to identify that quickly, then we can stop transmission, preventing for reintroduction in malaria transmission. As you can see here, the needs of the report actually rapidly increasing, very close to real time, from manually aggregating report in a high settings into immediate notification in low transmission setting and elimination setting. Some of you may already notice that in Indonesia now we implement what we call as strategy 1, 2, and 5, meaning that new cases have to be identified within 24 hours and need to be reported within 24 hours. And then in the second day, we have to do epidemiological investigation, and then by 5th day, we need to do intervention in the community to prevent further transmission. In many Southeast Asia settings, including Indonesia, then early detection becomes more challenging because, in Indonesia, we have all different species of Plasmodium, malaria, including the Knowlesi, and also it is challenging to identify in where and in which population actually the remaining malaria transmission is occurring. I stole a paper, a screenshot of papers published by Prof. S.Si and colleagues. I think it was in 2014, actually highlighting the importance of early detection in the context of Indonesia itself. So the paper suggested that lack of early detection could lead to reintroduction and even outbreak of malaria in area entering elimination. And Prof. S.Si and colleagues highlighted factors contributed to the resurgence of transmission were returns of transmigrant or migrant workers entering their village, so meaning that they travel back maybe from Papua, high endemic setting to in this case, to Kulon Progo, and then reintroduce malaria. Also, there was operational challenge related to reduced numbers of village malaria workers, which then impacted the performance of malaria early detection. Next, we've done study, this was actually part of my PhD study, and we published it in 2020, where we also found that actually there was late detection that associated to outbreak of malaria in the similar setting. You can imagine that. Professor published that in 2014, and then even in 2020, we still experiencing similar challenge in terms of early detection. In this case, we discuss how diagnostic limitation and also VFX relapse cases and surveillance limitation can impact the early detection performance. And some studies have suggested several about diagnostic limitation. If you see here, the schematic detection limits actually give a illustration that even though we know PCR is the gold standard to detect a parasite in the blood, but then the current diagnostic tools being used in the field, in the clinical settings, are actually microscopy and also in some part RDTs. And you can see microscopy and RDTs are not perfect because they couldn't detect a low parastemia, or what we call as, for example, submicroscopic for microscopy. And another study published in Nature Reviews actually, and some other studies and reviewed by the WHO about the quality of RDT, about diagnostic, actually estimates that a consistent limit of detection of microscopy is close to 100 to 200 parasite per microliter blood, meaning that under that or below that, it wouldn't be detected by routine microscopy. And this challenge become more prominent in area entering elimination, because then, the microscopists, they are no longer used to, do the blood smear and check the blood and look into the parasite in the blood. From one of our studies, samples collected from Timika, Papua, we had nearly 2,500 individuals aged more than 1 year. Based on that alone, then we compare the positivity based on PCR and microscopy, and it turns out what we found is that close to 63% of falciparum and close to 70% of vivax infection that are detected by PCR are actually not detected by microscopy, which again imply that we have serious challenge in terms of diagnostic limitation. And here just pictures that I took from a published paper by my colleagues at the London School of Hygiene and Tropical Medicine, showing the detectability of malaria infection by RDT. As you can see it here, in low prevalence setting in this site, you can see like only few infection are detected by RDT, around 24%, 13%, and 6%. Here, close to 40% can be detected. Most of them cannot be detected. And in high prevalence setting, especially among adults, only 20% of infection can be detected by RDTs. I just took this one from a paper published from a study in Indonesia. Actually, the population is pregnant women, but I think it's still important. Even though now we know there's a, what we call as ultra-sensitive RDT, rapid diagnostic test. But based on this study among pregnant women, we can see that actually the sensitivity of the ultra-sensitive RDT is also quite low, around 20%, but the specificity is high. Also, it's quite challenging, right? The use of RDT in pregnant women, which we know are high-risk population, is not that good. And there's also another threat. So this one actually was highlighted in the World Malaria Report by the WHO in 2024. It is related with what we call as P. falciparum histidine-rich protein 2 gene deletion, meaning that in area with high prevalence of this deletion, RDT, the use of RDT even becomes more insensitive, because then most of the P. falciparum RDT are detecting this specific protein. So you can imagine in a setting with high, for example in here, with high deletion of PF-HRV, there will be quite high number of infection that cannot be detected by the RDTs. In Indonesian settings, actually WHO said there was only one study from Papua that shows that actually we do have this problem, but then again the evidence is very limited. So for those colleagues working on molecular or genomics, probably this is also a good research question that you can ask, try to answer, and you can better inform the public health intervention. Another challenge is related to asymptomatic infection. Not for those of you who experience malaria, I'm not sure whether you had a symptom or not, but there's a lot of studies suggesting that a high proportion of people actually experience asymptomatic infection. And I took the data from a paper published in Nature in 2015. Actually, the data are from Burkina Faso. They based their analysis and mathematical modeling using 251 samples. And based on this paper, actually we can see that only small proportion of the infection are actually here clinical, this part, clinical, and can be detected. But then 42% were asymptomatic and still detectable. But here, more than 50% are asymptomatic and then undetected by microscopy, which is this part of the graph. So that's a challenge related to asymptomatic infection. Another challenge related to asymptomatic infection is if people got infected but they don't feel anything, right? They are very likely not they will not be captured by the health system, right? Because they are not having any symptoms, so they just stay at home. But then many papers suggested that asymptomatic infection actually can contribute up to 30% of infection. So they are not sick, but they can contribute to infection in the population. Now, I tried to look for another type of challenges, and then I categorize it into one, what I call as operational constraint in here, basically related to, you know, healthcare workers' knowledge, attitude, and practices, limited resources, like, you know, like the early detection for malaria, based on the national program, actually are really depending on the performance of health cadres. And we understand not all districts in Indonesia have good cadres. Even maybe some of them have no money to pay the cadres. So we can imagine how that operational constraints can impact the early detection performance in malaria endemic setting in Indonesia. Another challenge is related to migration surveillance with massive mobility, a lot of undetected population traveling. Also, there's challenge related to health-seeking behaviors and community practice in some places, especially if it is related to indigenous population. Maybe they cannot be reached by our control program, by the early detection program, because, you know, they just have beliefs or practices that are not aligned with our control program. And also there's challenge related to hard-to-reach population, what we call as mobile and migrant population, including, you know, migrant workers, army, and so on. Our group published papers in BMC infectious disease in 2022, and some of the findings also highlighted this is operational constraint. Actually, we found that in Kulon Progo and Magelang, which was pre-elimination setting and elimination setting, we found that the probability of care seeking and testing for malaria is really heterogeneous. If you can see, if it is homogeneous, then the color will be just one color. But in here, it means that each health facility have different probability of getting people coming to the health facility and then test people for malaria. And we found that care seeking was higher at facilities who are still regularly providing anti-malaria drugs. And then we found that availability of functioning microscopy, because not all of microscopy are functioning, increase the probability of people being tested for malaria. We also published these papers recently, and we found in East Kalimantan, one of the remaining hotspots, we found that malaria infection is associated with forest-related activities during the night, imported infection among migrant workers, and also challenge related to undocumented workers. Sometimes we call it as illegal migrant workers because they are undocumented and they are hard to reach by the control program, by the early detection programs. So, in conclusion, early detection is essential to transform malaria surveillance into core intervention to be able to then achieve malaria elimination goal. Challenges in early detection are complex, spanning from operational challenge, diagnostic challenge, and political challenge nowadays, Prof. already mentioned. And I think these together highlight the importance of conducting future research that could address both diagnostic limitation and also operational or programmatic challenges. I would like to conclude my talk by thanking all of these colleagues contributing into our previous work on malaria. UGM, there's almarhum Prof. Supargiono, Prof. Elsa, Pak Doni, and other members and collaborators from the UK and also from the District Health Office and Papuan Health and Community Development Foundation Indonesia, and so on. Thank you very much. Welcome for discussion. Thank you.
Okay, applause for Dr. Henry. Dr. Henry, please just stay there. Yeah. So thank you for very informative presentations. So we learned that the lower the endemicity, the more challenging the detection of malaria. And then also thank you for bringing back our memory to 10 years ago in Monash, while we doing the spatio-temporal mapping to predict the next outbreak in Monash Hills. And also 5 years later, Dr. Henry and late Prof. Supargiono working to do the surveillance using our the serology approach. Yeah. Okay. And now we would like to invite all of the speakers on the stage. Prof. Erni, are you still there? Prof. Erni? You still there, Prof. Erni? Nggak ada. Okay. Ladies and gentlemen, now we want to open the Q&A session. So I would like to give the first opportunity to the participants that join here. So please raise your hand if you have questions. So 1, 2, 3. In the first term, I just take 3 questions, yeah? So the gentleman with the glasses, please stand up. And then the second one, the lady in body, yeah? And the third one, I think I will take from this group. Ada yang tanya di sini? Oh, the one that's already been infected by malaria. That's the request from Dr. Henry. Okay, thank you.
Okay.
Please.
Thank you so much for the opportunity, Prof. I want to ask to Dr. Henry. First of all, we have talked about the problem in detecting malaria with microscopy. That is skill issue. That is where there are variability in people's ability in detecting and spotting the malaria parasite. I want to ask Dr. Henry, what is your opinion in utilizing artificial intelligence to assist us in detecting the malaria parasite? Is there any evidence that AI can increase the sensitivity of detecting the malaria parasite compared with manual work alone? And my second question is, could we design a point of care PCR, just like in tuberculosis we have gene expert? Could we design the same thing, a PCR for malaria in Indonesia to be used to massive screening and identification of cases? Those are my questions. Thank you.
And your name is?
My name is Alvaro.
Alvaro. Okay. So maybe answer. Yeah.
Thank you. Really great question. The quick answer is, I don't know. I have no evidence on the use of AI on malaria, but I believe there's potential because we know there are a couple of groups working on the use of AI smartphone for TB diagnostic, which is also based on microscopy. So I think probably we could also do something around that, and I'm looking forward if any of you have any idea and then would like to collaborate on that. Second one, can we set up a PCR? We can if we have money. we can if we have money. But PCR is the gold standard, but it's not ideal in the field for some reasons. Of course, it is costly. It requires higher technical skills for the lab. Even like the sampling, it will add more complication, I guess, for clinical settings to do that. So I will say it is possible, but probably programmatically challenging. Thank you.
Thank you.
Test. Okay, thank you, Prof, for all the presentations, very insightful. I really want to ask, so firstly, my name is Abelia. I'm from the International Federation of Red Cross and Red Crescent Societies. So in IFRC, we are working really close with the Indonesian Red Cross or PMI. We also work really close with the community. So my question is very related to community engagement and accountability. Where do you think that we can include community in early detection? And also, do you have any experience working within the community for early detection in malaria? Thank you very much.
That's for me, right?
It's
Thank
addressed
you.
to?
Yeah. Yes. Only one question, right? It's related to community empowerment. Yeah, like I mentioned before, actually, the national guidelines said the early detection is led by health cadres, which means community. It is good in a way because then health cadre will have a chit chat early in the morning, I guess, before going to the market. That way they will know that who's visiting the village, who is now having a fever. That way they will do quick investigation, taking the blood and so on. But again, I think the challenge is related to financing. As I know, like for example, in Kulon Progo, they try to get money from industry, like CRO, right? Or CSO, CSR, yeah. But not all districts, I think, can do the same. And we know now there is Dana Desa, and some districts, they already exploring the potential of using that to support the health cadre in doing what we call as early detection. So yeah, so if you have a, like, initiative, for example, like the Zero TB led by TropMed, doing some more mobile active case detection, of course, then money, it's always an issue. So yeah, interesting to be explored. Thank you.
Okay, and the next question and this first termin, I think the ones with the black t-shirt. Is it? Are you? Kelihatannya dari sana. Ayo. Okay, introduce your name.
Thank you, Professor, for the time. My name is Arya Marganda Simanjunta from Riau. I'm a research assistant in Department of Internal Medicine. My questions will likely to be for Dr. Henry. My questions is more likely to be practical due to the microscopy and RDT, where sensitivity and specificity will consider to be low compared to PCR. My question would likely, in your opinion, how we can early detection for in low resource settings, because as you already proved to us that late detection will lead into reintroduction. But my question would be, how about in the low resource setting? For example, in Riau there are few cases of malaria that we found, and it is really hard for us to actually detect the case, and the patient have to go several various healthcare facilities, approximately 7 hospitals, until the patients actually diagnosed as malaria. So in your opinion, please also help me how we can early detect, especially in low resource setting. Thank you.
Okay, for the low resource setting. Okay.
For the low resource setting, right? It's a hard question, especially if you relate that into clinical practice.
Okay, yeah.
But for public health prevention, I mean, looking at it as a public health threat and then doing something that will enable quick action in the field to prevent the reintroduction of malaria, there are some groups of people proposing the use of serology to detect, to do the screening actually. So once they detect there is an increase on the antibody responses in the population, then even before they observe any clinical cases, then they will do certain intervention like redistributing the LLIN and maybe just do mass fever survey after that. And a lot of those um, approaches have been tested in African setting actually, which is also low resource setting. But in Indonesia, I know a study, sero study led by OCRU, Oxford Clinical Research Unit, also is now trying to validate an approach, serological approach, but specifically for Vivax, because we know Vivax, like Dr. Erni said, Prof. Erni said, that for Vivax there is a threat of hypnozoite carrier, right, which cannot be detected by blood testing because it's still in the liver stage. So one approach, public health approach that is currently being tested is to use certain serological tests to identify those people who potentially have hypnozoite and then treat them. But again, it is still in a clinic, in a study setting, so it's not public health practice, because, treating someone also who may or may not have the disease may also introduce harm, right, Bu Elsa? It's also related to GCP, you are a clinician, I think. So there is no simple answer to that. But I would like to say, I think there's promising tools related to serology that can identify very recent infection, close to new infection, I think. Thank you.
Okay, thank you. Now I open the second term. So is there any question for Pak Triwibowo and Prof. Erni? Prof. Erni is still here. Okay. If your question is for Pak Triwibowo, and then I will take your question. Yeah? You? Okay. 1, 2, and the man in the, the guys in the corner. Artika. Okay. You first. Please introduce yourself.
Thank you for the opportunities. My name is Surendra from Diponegoro University, and my question for Pak Triwibowo is, I believe that right now we are in the beginning of 1.5 degrees global temperature increase. Sir, do you think by the end of this year, do you see this 1.5 degree change in climate? Is it going to be significant in terms of creating a vector-borne disease expansion? Because I believe that most of the experts in the world say that 1.5 degrees is a reversible change, like we are going to go through in the future. So do you believe is it going to be significant in terms of vector-borne disease expansion, especially in Indonesia? Thank you.
Okay, thank you very much for the question. So I think, yes, this is going to significant, especially for the Aedes dengue transmission or chikungunya, because as we have already experienced and already evident about the expansion of the Aedes albopictus to area not only in equator area, in a tropical area, but subtropical area now is already expansion over there. So now we get information about the dengue transmission in some country in Europe, and this is really need to pay attention for everyone, because of in according to the Indonesian situation, maybe now we have a good and successful dengue control program. One of them is by using Wolbachia to control the Aedes aegypti. In the future, if we can control the Aedes aegypti very well, we should pay attention with the Aedes albopictus, because maybe they can change the rule for the transmission of the dengue. So and now in some place we identify they could breed in the indoor, not only outdoor. So I think we need to more study about this, and then maybe to make sure about this, the expansion and the increasing of the temperature will give impact for the vector-borne diseases. For malaria, so far we are monitoring for the impact of the climate change. So far, yeah, is little bit lower than the arboviruses. Thank you.
Thank you.
Okay, the next questions. I think the lady, oh, you.
Check. Check 1, 2, 3. Okay. Thank you, Professor, for the opportunity. My name is Surya from Monash. I have a question addressed to Pak Triwibowo. So as we have discussed earlier, because malaria is changing nowadays, especially in Indonesia, and we know that we have treated bed nets for indoor transmission, but I would like to ask, how is the effective measures to reduce malaria in terms of outdoor transmission? Because as we know, a lot of farmers have a secondary house in the farms, and these farmers are infected from those houses, but not in their daily house. So yeah, what is the most effective strategy to reduce this outdoor transmission? Thank you.
Okay, this is a good question, and this is, I think, a critical issue now related with the difficulty control for the malaria, especially for the outdoor transmission. We have some approach to manage the malaria vector control, not only by using LLIN and IRS, but also for larva source reduction. Actually, the larva source reduction is powerful in the past. Maybe if I already mentioned about the successfully Nicholas Hendrik Swellen grable to control the malaria in north coast of Java successfully in around 1920 until 1935. They just identify the biological characteristic of the larvae, and then they identify why the larva can be breed very well. So they add salinity from this breeding habitat, and the larva will die. And then they also add the water, fresh water from maybe the irrigation canal, and the larva also die. So the key is actually the larva only live in the optimum situation, especially in the coastal area, in the brackish water. So that's why the environmental management is essential to control, especially in area with particular species of the Anopheles, especially maybe Anopheles sondaicus, Anopheles epiroticus, by using management, environmental management. So this is already adopted with many countries in South America. My colleague also very happy with this successful approach, and then we will adopt this also for Papua in the near future. We already have a proposal, submitting proposal with Dr. Iqbal, and then we will try for 3 years to identify the effectiveness of the larva source management. So I think we also have one good experience about this in Freeport, in area in Kuala Kencana, because area Kuala Kencana is area with a free malaria surrounding with very high endemic malaria. They are using larva source management approach to control them. So they can do this and successfully. So we will adopt this for the community. Thank you. Yeah,
yeah, okay. And the last question in this term, please, Mas Arka.
Thank you. My name is Arka. I have a question for Pak Triwibowo. So I think when we take a look at biodiversity as a whole, a lot of animals and plants, species and subspecies went extinct. I would like to know whether the same thing is happening on factors, especially disease carrying factors, and from disease control perspective, if that is happening, is that a good thing or a bad thing? And is there any effect of having less diverse factors in the future? Thank you.
Yes, this is a good question, difficult to answer. But I think this is very important actually because of, we hope we still keep the diversity, biodiversity in the nature, because of even though we know that mosquito have a bad role for the disease transmission, but they have a good role especially for the life cycle of the maybe in the ecosystem. So for example, in Central Java, we have a good experience about this, especially in paddy fields malaria transmission. We have Anopheles aconitas that have important role for the malaria vector in the past, maybe in 20 years or 30 years ago. And we're using approach to control by using integrated vector control, by using cattle barrier, and also management in the paddy field. We release the fish, and then the fish will eat the larvae of the Anopheles aconitus, and then the density of the Anopheles aconitus will decrease, and then the mosquito will, when they will come to the village, cattle barrier will barrier them to come to the house. So this approach is very successfully, and now almost of the area in a paddy field is already eliminated for the malaria. But now we still have Anopheles aconitus, but there is no Plasmodium. So it means that I think it will be good. We can control the disease, but we still keep the biodiversity that very important for the ecosystem. Yeah, maybe hopefully, yeah, it look like I just discussed with the expert for the schistosomiasis in Central Sulawesi just 2 days ago. We also have same idea how to control schistosomiasis in Central Sulawesi. But the expert from Japan said that we can control the transmission, but we no need to eliminate all of the snail. So that's why the snail in Japan is still present, but the transmission is no transmission again and eliminated. So I think this is a good idea, and hopefully we can do this. Yeah, thank you.
Okay, thank you, Pak Triwibowo. So to make it more balanced, so the next termin is a question for Prof. Erni. Is there any question for Prof. Erni? One? Okay, please introduce yourself.
Thank you, Prof. Elsa. Good morning, Prof. Erni. Thank you for a wonderful presentation regarding your also your vaccine candidate clinical trials. I was wondering if your vaccine candidate it is just for Plasmodium falciparum and cannot induce antibody from Vivax. I was wondering if in the next stage or R&D stage in the future can be this both species can be included in the one candidate vaccine candidate. So it will be maybe it will be cheaper than P21 vaccine from the previous vaccine in the global. Thank you.
Okay, please, Prof. Erni.
Yes, Prof. Elsa, thank you for the important questions. And yeah, so I need to mention also here, maybe I missed to say that in the presentation, that it is true that the sporozoite vaccine that been on trial in Papua shown no protection at all to the Plasmodium vivax. So what we have now and has been developed by the Sanaria is to combine the protein of vivax into the Plasmodium falciparum. So then the administration of both of these protein from the parasites can then be hopefully induce the antibody response, cellular and also antibody and cellular immune response to the both parasites. But this has been developed and has been also being created by the scientists that they understand that there is no link or cross antibody induced by these different parasites. So then, like I already just mentioned, so they try to put the proteins of the vivax into the proteins of the Plasmodium falciparum. Then hopefully this will be able later stimulated both antibody responses. So both protection can be then achieved by only giving one type of vaccines. But I I realized that this might not already ready for a trial, but what is your the question is already tried to be solved by the scientists. Thank you, Professor.
Thank you, Prof. Erni. So I think there is no more time. Yeah, I'm sure that you still have so many questions, but time limits our discussion. So let me summarize the important thing from this session. The first is that malaria is still a looming threat. The second, climate change combined with land use changing, yeah, it will create the more expansion for the vectors and maybe impacting to malaria. The thing that we can do is do the innovation. The innovation can be at the preventive stage, like Prof. Erni deliver the presentations. We just choose which vaccines that really suitable for our population. Is that right, Prof. Erni? And then for the detection, let we refer to Dr. Henry survey study, yeah, Dr. Henry study using the serological approach. I think it can still be done in this recent years, yeah. And then from Pak Triwibowo, we can also still do the larva source management. Even though it's old innovation, but I think it still work, yeah. Okay. So I think that's the end of the session today for the malaria session. Now I would like to hand over the session to the MC. But before that, please give a warm applause for every speaker.
One more time, let's give your biggest applause for the first symposium led by Professor Elsa Herdiana, Dr. Henry, Dr. Triwibowo, and Professor Erni. Dear ladies and gentlemen, I know this is the afternoon already and it's time for the Friday prayer for you who have to do that. But before that, we still have a little information. The first one is about the Wolbachia experience. So about the Wolbachia experience, we are inviting all of you to join the tour sessions with the Wolbachia mosquito research team. If you're interested, just go to the booth and register yourself over there.
And also we still have the poster presentations booth as you had to lunch and break. We invite you all to explore the posters presentation display near the lunch area in Wiata Hall. Take a moment to view the poster, everyone, about the research and the innovation. And also, if you would like to have further discussion about the posters, the presenters will stand by in their poster around at 2:15 until 3:35 p.m. And also, you have a lunch time after this.
Yes, exactly. And we'll be right back at 1 p.m. sharp. One more time at 1 p.m. sharp with more exciting symposium, book launch, and another keynote speech from S.Si. So my name is Rima.
My name is Yopi, and enjoy your lunch time, everyone.